So you'll do it in supine and prone, standing and walking. Because you need to know something about the gait. When you examine the hip, you say that I'll examine the patient in supine, prone, standing and walking. And I used to tell the students, always prepare for me a short presentation about the type of gait. And they used to give it to me in writing, all the type of gait. Because you should know something about the gait. Type of gait, and how when you see the patient walking, you know what type of gait he got, and accordingly you know the disease, almost. Anyhow, now let's go to the local exam of the right hip after you did position and exposure, and the position now is in the supine position. Right, do it.
First start the hip flexion without knee flexion and with knee flexion.
I know that, you know what, you have to do first inspection, palpation and movements. Now jump to the movement.
First we start hip flexion with two movements.
Active and passive.
Active and passive.
Right, active and passive. Right, which one you start with, active or passive?
Active, then passive.
Alright, now let's do the passive.
Start with knee flexion. The normal measure is 120 degrees. And without knee flexion, like this, the normal measure is.
No, but when we do the active movement of the hip flexion, always we flex the knee. We flex the knee. So flex the knee, get full flexion. No full flexion. Carry on. يا أخي.
الأخير.
هذا آخرك يا أحمد.
اللي هو قبلها.
يلا دوت. أنت كملها. هذا حد لا غيرك لا يجي أكثر. Perfection. All right.
Sorry, go خربان.
All right. Extension.
Extension in prone position.
All right.
Lift the leg.
لا.
So lift the leg up.
Extension. With flexion, right. Back. This is flexion and extension. Then flexion and extension. Then what else?
Abduction and adduction. Abduction. This is abduction. And this is adduction.
This is what did you do wrong?
We should flex the other. Here is a pelvis trying to compensate. You can do one short and
What's the best?
ثبت السليمة.
كيف تبص؟ How do you do abduction? And to be sure that this movement is only in the hip. Stabilize the pelvis because the pelvis could move when you do abduction. Do the abduction now after you stabilize the pelvis. Abduct. Keep your arm. Put it in the iliac crest. نزل ايدك كده. Right. So you'll hold almost two iliac crest. And you know that when you do more abduction. Now the pelvis start to move. You could feel the pelvis start to tilt. Back. So this is your 0. Abduct. Up to 60. Before the pelvis tilt. You understand? So you abduct until you feel that the pelvis start tilting, and then you know that now this is basically hip abduction. If I'll do in the left side, I'll stabilize the pelvis like this. If he's a child, I'll put my one hand in the two iliac crest. But here I have to put the whole arm. So I know that how much abduction I'm doing. This abduction is basically hip. More than that, now the pelvis start to move. So this is 0 to almost 45. Okay. Alright. Then abduction is the same. Stabilize the pelvis and then cross the leg. Yes.
0 to
enough.
25.
Alright, yes. Right. So this is flexion, extension, adduction, and abduction.
Internal rotation and external rotation.
Do it.
Two movements with knee straight. is the external rotation, and this is the internal rotation.
It might be doing by flex the maybe and stabilize the knee and you
اللي هو جالس.
flex the knee at 90 degree, okay, and you do like this, external rotation and internal rotation like this to stabilize the knee, and you ensure that only the movement in the
هذا external.
Do it again. The proper way.
like 90 degree.
Right, 90. 90 hip, 90 knee.
Okay. And
Then
you stabilize the knee by your
right.
hand, and you move to ensure that
What is this?
antenna.
With hip and knee flexion.
What is this?
الانتنا rotation.
مو قاعد يستوعب.
antenna rotation.
يعني مو العظيم.
يعني
سبحان الله العظيم.
Okay. antenna rotation, external rotation. Okay. So, and after that we go to special test and measurements.
سالفة يا ريال.
Internal rotation directly. So we have مرة خمسة.
ايه but the thing that you did is completely wrong. يعني not zero then arrow down. Because you're moving the foot. And you're moving the foot in inversion and inversion, you said that this internal rotation. Not only zero and arrow down. Right. Because if you want to do it while the knee is extended, this is like this. This internal and this is external rotation. Internal external rotation. Not here, you're moving like this and like this. Right. You're moving like this. This internal, this external rotation. But when you do it with the knee flexed, right, this one external rotation. And this one internal rotation. Because it's a polar socket, so you said internal external rotation, adduction, abduction, and circumduction.
Special test.
All right, do the thumbs.
My left hand will put it in the lumbar spine. Actually, in the normal, you didn't touch and you didn't feel the lumbar. The other hand, I put it in the.
No, there is a normal lumbar lordosis. The normal people, you get the normal lumbar lordosis. So you feel the lumbar curve. But what do you have to do? You have to use a better couch than this one. This is very soft. It has to be a bit rigid. All right? And then you have to remove this one. Right? Because it has to be flat. You understand me? Fully flat then, and only then you can do the good Thomas test. But now we'll do it with this one is in. Yes? The lumbar spine.
Lumbar spine.
Right.
I will. This is affected knee. This
Right.
affected knee. I will flex the knee. Flex the knee until I see the other leg will be flexed. I will feel first when I flex the knee, I see the flattened perfect. Then
You know how do you do the Thomas test?
Examine the right, I will flex the left.
No, we're testing the left side.
Okay. I put my hand on the lumbar area, then flex the knee. If it is positive, the affected knee will be
لا but you flex the knee until what?
until I feel the lumbar spine.
the perfect back down.
What do we call this?
Disappearance of
أيوة. Disappearance of the lordosis. Okay. They have a special wording for that in English. Until you obliterate the lumbar lordosis. Right. The lumbar lordosis, as you see, disappear. The back will become flat. Right. So you flex until the lumbar lordosis is obliterated, become flat. Do it, please.
The affected leg is the left one. I put my hand under the lumbar area. There is normal lordosis. I flex the normal leg completely, and by that I obliterate the lumbar lordosis. If there is if this the left leg is affected, it will be flexed like this slightly to compensate the affection أو البليرو. Then خلص هذا التست بس في other test.
Then now if you obliterate the lordosis, and it carry on in the flexion until the lordosis is obliterated.
Okay.
All right. If this one is elevated like this, what does it mean?
Positive.
What do we call it?
Thomas test.
Positive
Flexion deformity.
fixed flexion deformity by 30 degrees. The degree which is there here now it is 20.
Okay.
You understand?
Yeah.
So you obliterate the lordosis. If there is no elevation of the other limb, this is normal, negative Thomas test. If it is elevated, it's a positive Thomas test, which indicates that there is fixed flexion deformity with the angle which is elevated.
Which is
That's why you didn't need to overcome the procedure. Put your hand, flex the hip, flex the hip, flex more. Now if you overdo it, even in a normal person, especially in this man, you will see that this one is elevated. If you overdo it. Your aim is just to obliterate lordosis, don't overdo the things. If you overdo, see, look for him. Overdo, there's 10 degree already elevated, or 5 degrees. If you overdo, it will be elevated automatic, because the whole pelvis will move up.
Be forward.
So your aim is just to obliterate lordosis.
So
then you stop.
around the 90-90 flexion of hip
It could be 90, it could be 100, 110, until his lordosis is obliterated. But don't overdo it. Once you obliterate lordosis, stop and then look for the other limb. If elevated, it means that there is fixed flexion deformity by that angle. All right, then next.
no, sorry.
So this is how you use more. You are mixing between the spine and the hip examination. So, which is which? Trendelenburg.
Trendelenburg test.
How do you do the Trendelenburg test?
لو سمحت ممكن توقف؟ واقف تسوي لي تسوي ترفع وجه. I suppose that the left side is the affected one.
The disease.
اوكي. لو سمحت ابغاك عفوا توقف على رجلك اليسار. ايوه على رجلك اليسار.
وقف
على رجلك اليسار. Affected leg. Okay. This is negative Trendelenburg test because the patient pelvis is tilted toward the the positive test is.
So you examine the patient in 3 positions. First, either from his front or from his back, and you look for the shoulder and the iliac crest.
Okay.
So now you look for the patient like this. You look for his shoulder and for his iliac crest. Either examine him from front or from the back. The third way is you ask him to put weight in my arm. All right? And then you ask him to stand on the disease, on the affected side. And he elevate the normal. Elevate the normal. So we're testing now the left. So what will happen? Now what will happen now? You can see that the shoulder drop towards this side, the left. Iliac crest, if we feel that this one is dropped, this one is elevated. And when we put the weight, we know that he's putting more weight in the left side compared with the right side. So this is all negative Trendelenburg test. If you get positive, you have to wait for a while. Wait for at least 20 seconds, because possible the muscle will get fatigued. All right? If it is positive, turn to the left side. خلي
Turn to the normal
yes, like
side.
this. So he will put more weight on this side, and the iliac crest will be elevated, and the disease side will be elevated, and the shoulder will be elevated the disease side.
And it indicates
So what does it indicate?
abductor
system.
Vector system.
Positive Trendelenburg. It means what?
Vector system.
Abductor is weak. Due to what? You may at least 10 causes. 10 causes for abductor weakness.
تروما.
شمري ولا لا؟ Tell us. Trauma fight. أنا trauma will give
Gluteus medius and minimus muscle.
gluteus medius and minimus. Now this test is testing which muscles? You We said the abductor. What are these abductors?
Gluteus medius.
Medius and
And minimus.
minimus. All right, medius and minimus. Supplied by
superior
gluteal nerve. Good, superior gluteal nerve. So, give me causes. Originated where? This originated where? The gluteus medius and minimus. Origin and insertion. Origin.
Anterior superior.
So, the iliac crests originated, iliac crest, and inserted where? Greater trochanter. So this distance, iliac crest and greater trochanter. So these are the two muscles. Now, give us now causes for positive Trendelenburg. Nerve regions. Fracture where? Intertrochanteric. If it's acute, he cannot stand up with that one because you want him to stand up with that one. Isn't it? If it's acute, he cannot stand up because of pain. But when there is fracture non-union, there is an old neglected fractures, not any fractures. What else? Rheumatoid muscle to affect the joint. Chronic hip dislocation, chronic things. Chronic hip dislocations. Either or congenital. Painful, but since it is old chronic one, he could stand up and walk. The way that he's walking with a waddling gait, you know, waddling gait. All right, at that side. That's why because of this weakness, you see it more in DDH. So if you get congenital hip dislocation, also you'll get this waddling gait. Causes.
Nerve injury.
Muscle weakness, like muscle dystrophy. If you get one limb muscle dystrophy, he will get also positive Trendelenburg. Limb girdle muscle dystrophy. Causes. Somali. Avascular necrosis, which is so common here. Avascular necrosis of the head of the femur. And this will make the neck a bit short. So when the origin come near to the insertions, the origin, iliac crest, they come near to each other, you'll get positive Trendelenburg. Because the muscle needs to be under tensions to work. If it's lax, it doesn't work well. So the origin will come near to the insertion if there is avascular necrosis of the head of the femur, due to sickle cell, Berth's disease, primary osteonecrosis. All right. All of this, if there's an avascular necrosis of the head, it will end up with a positive Trendelenburg. Right. When you get deformity of the neck, like coxavara, coxavulga, all of these will end up with abnormality in the lever arm between the origin and the insertion. So there is more than 20 causes of positive Trendelenburg test.
عارف دكتور الكوكسافارا والبلغة النك تكون في الفارة يعني داخلة على towards
Coxavara, the angle, the neck shaft angle is 135 degree. When you do coxavara, it become more, it become 90 degree, 95. Coxavulga when it become 150, 160, 170. The shaft neck angle.
لها علاقة بالتوينج في الchildren.
This is something else. No, this is another disease. Right. What else in the hip? In the hip.
Special test again. Now neurological assessment of the lower limb.
All right. Other test.
Neurological examination. We go to neurological.
Now we said the other test. Like what? No. You get the Ortolani and Barlow's. What are these two tests? Right. Ortolani and Barlow's. These are in infancy with these two tests for hip dislocations. For congenital hip dislocation, we do these two tests. I wanted to describe this test. How do we do these two tests? Ortolani and Barlow's. Today, if you do have time, or even after the exam, it's for your teaching purposes. You go to the nursery and try to take a newly born baby and ask the pediatricians or the neonatologist, please show us the Ortolani and Barlow's test. And Barlow's test. It's a very simple test just to know if there is a hip dislocation or not. Because DDH is quite common in our area, in the kingdom. So possible tomorrow you'll be primary care, you'll go to dispensary, you want to give vaccinations. And they ask you, before you do vaccination, please do Ortolani and Barlow's test to test if there is any hip dislocation. So you try to note for the sake of science, not only for the exam. Thumb, and middle finger. Thumb in the lesser trochanter, middle finger in the greater trochanter. In a child, in a baby, you can do that. You can put your hand, thumb in the lesser trochanter, middle finger, the greater trochanter. As if like this. If I could put my hand in the lesser trochanter and the other one in the greater trochanter, both like this. Then I will try to abduct gradual abductions. When I abduct, while I'm feeling, will it relocate? Because when you abduct, if it is dislocated, it will relocate. Then you will feel a click. All right? So this is a positive test. Or you get from abduction to adductions. Also it will dislocate and then you will feel a click. So either you feel a click in abduction when you relocate, or you feel a click in adduction when you dislocate the hip. So the moment that you feel a click, you said, well, this is a case of suspicious of hip dislocation, because orthoambulosis. Those who pass the age of 1 year, quite difficult also to do for them, or when they become chubby, some of them, he's 12 kgs weight when he's at the age of 8 months. So you can't do the orthoambulosis test in a nice way. So we do something called telescopy. Telescopy, we flex the hip and the knee like this. And then we telescope as if we push it in and down, in and down. And I put my hand there and then. He's a baby, so I can do it like this, in and out, while my hand is in the hip. And I can feel if it comes in and out. I compare to the other side. As if I'm trying to dislocate and relocate, dislocate and relocate. Called telescoping, like telescope. My hand in the knee, and the other hand is in the hip. And then push it in and out, in and out. Clear? This is at least theoretical wise, but if you know it, you will get a grace mark. If you don't know it, you will not lose mark in the exam. Clear? All right. Only Thomas Trendenberg. Right. But in case that if you ask, you can tell him about the ortholine parlors and telescopy sign for the hip dislocation. All right. So we finish from the special test for the hip. What about the hip measurements? تفضل يا فارس الدهناء. Who knows? قم يا محمد. قم برا طولك. big zero or zero with arrow down.
باقي سهل يذكرها بس.
يلا tell us how do you do the measurements.
Medial malleolus. طيب إلى anterior superior للكسمان. طيب. Then we take from medial malleolus to the ناخذ القياس كله.
الصوت الطوارئ. القياس.
في true
Good.
في true.
So always there is true and apparent. Which one will start with? All right. Which one will start with? Which one will start with? Apparent or true? All right. Do the apparent. So. It's an exam, the exam is a few days from now.
Bring it align to the midline, then from
So, Berdad.
We fix the pelvis if there is any deformity to take good measurement.
Somali, idea.
The one of measurement?
Yes.
I will start. There is longitudinal pelvis.
Excellent. So there is always longitudinal and circumferential. Which one we will do now? Longitudinal, circumferential, we'll do it later on. Then
I start by apparent.
Apparent and true. You start with the apparent. How do you start with the apparent?
Yes, first if he has deformity, I will bring it all the neck into midline.
Good.
And measure from the anterior spine to anterior superior to medial.
Apparent.
from the
umbilicus.
Umbilicus.
Or the mid process.
Or the process to the medial malleolus. All right.
Yes.
So if there is any deformity, you don't square the pelvis.
Yes.
here. But you bring both legs parallel with each other and on line with the midline. In the apparent, bring both legs together, parallel to each other and on line with the midline. Then you measure from the sternum or umbilicus to the medial malleolus. Now let's say that there is a difference, 5 cm. This one is 55 and the other one is 50. So there is discrepancies in the length apparently by 5 cm. Alright then.
Then I go for true.
How do you do the true length?
If he has deformity also, I will bring the other limb normal.
Even if it doesn't have deformity, you have to say that you have to do what?
Square
Squaring of the pelvis. Now if there is a deformity, you have to.
But by this maneuver.
How do you square the pelvis?
By simulate the deformity in the other limb.
Good.
normal.
So let's say that you get abduction, fixed abduction, yes?
Abduction.
So
I will do this.
abduction the same way. By squaring the pelvis, what does it mean?
The iliacs both are in the same
Come
limb.
and do it. Both iliac crest and online
Yes.
and
Midline, midline.
perpendicular with the midline. They're forming one line. Even like this, they will form one line. Even like this, they will form one line. But one line and perpendicular with the midline. So if you iliac crest and the other iliac crest, they are forming one line and perpendicular with the midline. Good. Then
And measure from anterior cervical spine to the medial malleus. If there's discrepancy, I will determine this discrepancy, is it in femur or tibia, by measuring from anterior cervical spine to adductor tubercle for
adductor
or
tubercle,
medial
good.
condyle.
They call adductor tubercle or medial
This for femur.
tibial condyle.
And from adductor tubercle to medial malleus for the tibia. If there is difference, let's for example in the femur,
Right.
I will do the Bryant and Schumacher test.
Alright.
I mean if the in shaft or the in neck of the femur.
شفت هونك
تلوموني إذا قلت لكم أعطي 10.
دكتور كذا enough يعني ولا go to شمال؟
هو بيقول لك if there's time, do the شمال. So he finished the test in 3 minutes. But when you come, you'll finish the test in 10 minutes. And in his 3 minutes that he finished the test, we'll stop and we'll stay joking and we'll ask him different questions for different things to give him more grace mark. Right? And you'll see that in the exam, people they will stuck in one station and people they will move like smoothly in the other station because they know it well.
Even the time.
Okay. Clear? Test in the elbow and the stability. It means either stability or impingement. Here, basically, it is stability. It's a hinge joint, like the knee. So we stress the joint in some degree of flexion or in full extensions. And also we stress the elbow in varus, in flexion and in full extensions to see if it's stable or unstable. On top of that, usually you may get posterior elbow dislocation. So you can flex the elbow to 90 degrees and then push in and out to see if it's stable or not. It's usually stable because if it's unstable, it's very painful if it dislocates. Yes, this is to test for posterior and anterior instability. Like the drawer test, as if you are doing the drawer test. It is just think the elbow like the knee. It's a hinge joint. All right. So you can flex the elbow and then push in and pull out to see if it's stable or not. Usually it is stable because if unstable it's very painful. And then also you do it in full extensions to test for the collateral ligament. All right. You do it in full extension and some degree of flexions to test for the collateral ligament. Full extension and some degree of flexion for the lateral collateral ligaments. The elbow is unstable when we get 2 out of 3 is damaged. What are these bony landmark or bony pieces that when it's fractured or damaged, you will get elbow dislocation. Radial head. Coronoid process. You remember the olecranon? The anterior part of it is called coronoid process. So that coronoid process when it's fractured, or the head of the radius, or the ligaments. So either coronoid process, head of radius, or ligaments. 2 out of 3 when it is damaged, coronoid, head of radius, coronoid, ligaments, head of radius, you will get instability. Lateral medial. Alright. And then the other test, in the special test, you look for the tennis elbow and the golf elbow. Tennis elbow, it is at the common extensor, the origin of the common extensor, which is the lateral epicondyle. The lateral epicondyle. If there is tenderness here, it is possible positive for tennis elbow. But we have to stretch that common extensor of a wrist. So we test it, we extend the wrist against resistance. Look for his extensor now. Become very tense. And if you get tennis elbow, he is pulling over the origin of the common extensors. So it will become very painful and tender. Alright? So this is for tennis elbow. And then you do the same for the golf elbow. You are testing for golf elbow. It is the common flexors. Flex. Now he's tensing his flexors. And the origin of the common flexor is also in the medial epicondyle. If it's tender from the medial epicondyle, once you do palmar flexions of the arm, it indicates that there's a golf elbow. So you test for golf and tennis elbow. Right? وصلى الله على نبينا محمد.